I'd like to welcome everyone to the fourth installment of our discussion series on advancing health and social justice. My name is Stephen Swartzer, and I'm the Associate Director for Academic Programs in Fordham University's Center for Ethics Education. The Center for Ethics Education, which is directed by Dr. Celia Fisher, was established in 1999 as an interdisciplinary cross-campus unit at Fordham. The Ethics Center embodies Fordham's commitment to intellectual excellence, social justice, and human dignity through the promotion of ethics education, research, and public dialogue. Our programs include an interdisciplinary master's degree program in ethics and society, an advanced graduate certificate program in healthcare ethics, the HIV and Drug Abuse Prevention Research Ethics Training Institute, or READY, that has provided a significant amount of support for our talk series, and an undergraduate bioethics minor. In addition to these programs, we're also really excited to have public-facing ethics and social justice programming that engages people in conversation about issues of contemporary social import. So that brings us to today's conversation about mHealth, access to care, and ethics. And we're really excited about the turnout tonight and that this new online format has enabled us to broaden the reach of our programming. But before I want to introduce our participants, I think it's important to say a little bit about our procedure for this session. For the first part of the discussion, we will have the panelists tell us a little bit about their work and how it connects up to this topic. Then we will have a roundtable conversation among the panelists. And we are going to be really happy to include questions and contributions from the audience. But for the format for that, we're asking you to submit discussion questions through the private chat feature. So you can submit the questions either to me or to Dr. Elizabeth Buchanan, who will be moderating the conversation. And we encourage you to send your questions at any point during the conversation. And so now I will quickly introduce the panelists. So we have Dr. Randolph Hubach, is the director of the Sexual Health Research Lab at Oklahoma State University and associate professor of rural health and rural health at Oklahoma State University Center for Health Sciences. Then we have Dr. Alexis Roth, associate professor in the Department of Community Health and Prevention in the Dornsife School of Public Health at Drexel University. We have Dr. Roman Shrestha, an assistant professor in the Department of Allied Health Sciences and a principal investigator in the Institute for Collaboration on Health Intervention and Policy at the University of Connecticut. And the discussion tonight will be moderated by Dr. Elizabeth Buchanan, who is a research scientist and the director of the Office of Research Support Services at the Marshfield Clinic Research Institute. And now, with no further ado, I will let Dr. Buchanan take it away.
Okay, thank you, Steve. It's such a pleasure to be here this afternoon with everyone. I think these sessions are great, and even though we're in this modality, I think it does allow so many more of us to participate. So thank you for organizing and bringing this together. I'd like to give a special thanks to Dr. Fisher and Rima Jabber for their help in coordinating. As Steve said, my name is Elizabeth Buchanan. I'm a senior research scientist and director of the Office of Research Support Services at the Marshfield Clinic Research Institute in Marshfield, Wisconsin. And today we're at about a -3. So all of you who are in warm places, be thankful. In this session today, mHealth, Access to Care, and Ethics in the Age of COVID-19, we are going to hear from our three presenters on their current research using mHealth. This is a term that's gotten a lot of play in the past year, but these three researchers have been involved in this domain much prior to the COVID pandemic. When we talk about mHealth refers to the concept of using mobile devices such as mobile phones, tablets, smartphones in medicine and public health. mHealth applications include the use of mobile devices in collecting community and clinical health data, delivery and sharing of health information for practitioners, for researchers, and patients as well. We're talking about real-time monitoring of patient vital signs, And mHealth also includes the direct provision of care via mobile telemedicine, as well as training and collaboration of health workers. So the domain is quite large. Today, we're going to hear three different experiences with mHealth. And without further ado, I'm going to start with Dr. Alexis Roth and turn it over to Alexis. Thank you.
So as Elizabeth mentioned, I'm Alexis Roth, and I am the founder of the Health Equity Advancement Lab at the Dornsife School of Public Health. It's my pleasure to be with you today and to talk a little bit about the opioid-related overdose crisis in the era of COVID-19 and specific implications for mHealth. Next slide. So I'll start with just a bit of background to get us on the same page. We all probably realize that reducing overdose mortality is a top public health priority. Importantly, preliminary reports suggest that the COVID-19 pandemic has exacerbated this ongoing opioid-related overdose crisis, and its effects have been particularly acute among African Americans and Latinos. While a host of interventions have been deployed to reduce overdoses, most require active engagement, either by the person who uses drugs or a nearby peer or responder. While these interventions, such as naloxone distribution and overdose prevention programs or fentanyl testing strips, have an incredibly important role to play, the majority of deaths occur because individuals are using alone, without an observer to respond in the case of an overdose. This signals the need for interventions that can passively monitor signs of overdose and that can deploy automated real-time intervention when it is needed. To date, this approach has not been successfully implemented, but it may be possible now in this new era of mHealth. Next slide. So BioSensed is a feasibility, acceptability, and empirical ethics study of using a wearable biosensor to monitor physiological signs of opioid use set in Philadelphia, which is one of the cities that has been hardest impacted by the ongoing opioid crisis. To conduct the study, we identified and sequentially enrolled 16 participants from Unity Philly, which is a larger pilot trial of a smartphone-based application also designed to reduce overdose. So here is an mHealth intervention, well, an mHealth study based within another mHealth study. All of our BioSense participants reported using opioids 3 or more times a day prior to enrollment. They were equipped with the Spire Health Tag, which is pictured on the right corner of the slide. This device is about the size of a business card, and it's adhered to undergarments. So the lining of men's shorts, the inner wing of a woman's bra, and the goal of that is to make sure it has near constant contact with the skin in order to measure respiratory rate, which is a hallmark physiological response that we need to monitor when trying to identify overdoses. So for this brief talk, I'm just going to focus on the qualitative portion of the study, which included one in-depth qualitative interview after participants had completed 5 consecutive 24-hour periods of monitoring in which they were asked to wear the device, and then they came into the office for these daily drug intake assessments. Next slide, please. So through our qualitative exploration, we wanted to understand how the context in which people live, procure, and use opioids impacts the acceptability of a biosensor to monitor physiological signs of opioid use, and how participants characterize risks and benefits of passive yet continual monitoring in light of this context. Next slide. So to answer these questions, we turn to Zinbergs Framework for drug, set, and setting, which organically emerged from our data during analysis. This framework posits that properties of the drug itself, how it's used, the mindset of the person, as well as the physical and social setting in which drug use occurs, influence drug outcomes. We used this framework to understand the context of participants' lives and how the use of a biosensor might be perceived within that context. You'll see in the next few slides that as I present my results, I'll frame them within each of these constructs. Next slide. So the construct of drug emerged frequently in our analysis of participant narratives. Participants were keenly aware that the drug market had changed considerably and not always in desirable ways. They described the unpredictable purity and potency of the drugs they were able to access as serious, scary, and as a mystery. I'll give you just a moment to read the quotes so that you may interpret the participant perspectives for yourselves. Next slide. SET was also important for understanding acceptability. Our sample had long injection careers and considered themselves as savvy and experienced, knowledgeable about drugs and how to use them safely. Most expressed taking steps to avoid overdose in the context of not being sick. Here, sick refers to the painful symptoms associated with opioid withdrawal that participants were compelled to avoid even in the context of an unstable drug market. Next slide, please. Participants characterized the neighborhood where most lived, bought, and used drugs as a potential threat to be guarded against. They reported being mishandled and treated poorly by the police, emergency medical services, as well as members of the community at large. For these reasons, they were fearful of what might happen should they overdose and be unconscious in public. Some noted that a desire to avoid these stigmatizing experience, as well as theft, may be enough of an impetus for someone to use alone, even though it is a risk factor for overdose. Next slide, please. So when we think about how does drug, set, and setting influence the participants' characteristics of the risk and benefit of continual monitoring, here's what we found. Context is really important. There were few perceived risks and no real harms associated with the device itself, which is attributed to its discrete design and placement. There was little reported concern about passive surveillance of this stigmatized and sometimes related illegal behaviors, especially given participants were in a neighborhood where public drug use is uncommon, and they were unconcerned that their use would matter to authorities. In addition, people had long drug use careers. Many had gone to rehabilitation and were in recovery or had been in recovery, and so they were more comfortable talking about their drug use more broadly. Participants reported few direct benefits from passive monitoring, but they talked about learning how the effects of drug use was on their body as a frequently named indirect benefit. So knowledge was really crucial. So was altruism. There were also many perceived benefits of passive monitoring if it could be automated to trigger some type of real-time response. So we asked about, well, what if the device could sound an alarm? And they were very interested. What if it could trigger first responders? And they were very interested. What if it could auto-inject naloxone? And people were interested in that to a little bit of a lesser extent, but it could be a critical intervention. Just a little bit more research would be needed to be done to make sure that something like that is feasible. Next slide, please. So I'm going to give my acknowledgement slide while I summarize for the sake of time. I think what's important to note from what we've learned through these conversations in this singular setting with a very small sample is that mHealth interventions could play a pivotal role in ending the opioid overdose crisis, and they are particularly relevant now in the era of the global pandemic. The participants we interviewed were interested and excited about these types of interventions, and most perceived that the benefits would outweigh the risks. Thank you so much to the participants, the research team, our funders, and to you for your attention. And I look forward to talking about mobile health and overdose and the other types of interventions that my colleagues are going to talk about during the roundtable.
Thank you so much, Dr. Roth. You've given us a lot to think about in the first presentation. We're now going to turn to Dr. Randy Hubach. Randy, why don't you take it away?
Thank you, everyone. I want to echo what my colleagues have said, that we're really appreciative of you being here and look forward to kind of this conversation going on. And so today I kind of want to have a brief conversation related to the use of mHealth as a modality within the rural context. And I think a lot of times when we come from a public health framework, we look at how these interventions components are used within the more urban context, but don't necessarily account for the rural context. And so what is different than rural, or what is rural? Too often, I think we try to think of this as a dichotomy, that it's either rural or it's urban. In reality, I think we need to look at reality as a gradation. And part of that is influenced by where we are reared in our own kind of conceptual lens of what rural looks like. So for some of you who have grown up in New York, LA, Chicago, if you go to a state institution that's in a college town that still has 60 to 70,000 individuals, that still has a Target, a Walmart, it might feel rural in a concept based to what you know. Here in Oklahoma, we see this where people are coming from Dallas, Kansas City, and the like. And within the Stillwater area, there's a population of about 30,000. It still has some of the convenience of a larger town, but it's seen as kind of a rural concept. However, if you come from a small town of 1,000 to 2,000 individuals, and now you come to this college town, you're like, this feels more of an urban environment because you have a Best Buy, you have a Target, you have a Walmart, whatever that might be. And so when we think about the rural context as well, we're starting to look at, well, how does that cultural aspects come in? We know within rural communities, traditionally, there's a little bit more social conservativeness. We understand how people are interwoven together, the role of faith communities and how that might intersect the way that we engage in health, how we engage in public health programming too. And so when we think of the rural context within the use of mHealth, and we start to look at, a lot of my work is with men who sex with men, so gay, bisexual, and other men who sex with men. What we know within the rural community is that a lot of these men are estranged from other men who are like them. And being estranged by individuals can lead to increased loneliness or feeling of isolation. As well, you might have barriers to care for medical and mental health care, so you might be less likely to be engaged in care, similar to some of those urban counterparts. Similarly, what we see is that a lot of our rural communities are classified as health profession shortage areas by HRSA, the Health Resources Services Administration. So you're already living within a community that has fewer providers within it, with some of these towns having 1 or 2 physicians. And so you might have access, but you might not be amenable to it. What does it look like for those providing culturally competent care for sexual and gender minorities? So just having the presence of a provider doesn't necessarily mean they're an affirming provider, a provider that's going to meet your needs. So we would have that decreased access of affirming providers. And what we see within these rural communities is usually this increase of substance use, decrease or more negative mental health, including loneliness and isolation. And as we see here, kind of this syndemic relationship between, here in Oklahoma, Oklahoma has a predominant burden of HIV cases within our rural communities, similar to some other states that are in the South, where we have this kind of perfect storm of social and cultural factors that put communities at risk. And so we know that there's these issues and things that we want to go ahead and address within these communities. And what are some of those approaches that we can then take? And what has really been advocated for is how can we use telemedicine and mHealth as a way to kind of overcome these barriers, but allows for us to engage in HIV STI mitigation and things that can be expanded from a clinical setting back to things that could be done at home. So a lot of what my team has been looking at here at Oklahoma State University is how can we leverage mHealth in combination with at-home testing. We know that our barriers to care, to access HIV and STI screening, just physically, but also culturally. So if we send you an at-home kit to where you can get screened, get your results through an app-based program, online, text message, whatever that preference might be, how can we also give you a behavioral intervention through mHealth and other modalities that will help decrease your risk and likelihood of HIV or STI acquisition in the future? And so a lot of the work that we've been doing, piloting these modalities, things that they introduced READY, which is our HIV Research Ethics Institute, overseen by Dr. Fisher as well. I collected some pilot data to see, well, what are our individuals' amenability, or what are some of those concerns related to the use of mHealth within the rural context, but also being a rural and sexual gender minority. And one of the biggest things that started to emerge was this issue of privacy and confidentiality. Most of us might not pay any attention to, if we think about the screens on our phone, what those apps, the cover might look like. They tend to be benign. And so when we're developing an mHealth intervention that might be app-based, well, what does that little graphic look like? Could it be something that outs you? What if someone else sees it? Similarly, if you have a login screen, traditionally, a lot of HIV prevention programming that's working with sexual minorities, gay and bisexual men, are really looking at identity formation and community building, of bringing like individuals together and building on this concept of identity. Well, what we see within the rural context is through our research and through the literature too, is that individuals might not identify as part of the larger LGBT community because of a lack of community within those rural spaces. But additionally, some of these men might identify as heterosexual, but only engage in sex with other men. So engaging in the behavior that puts them at risk for HIV or STI acquisition, but I'm not identifying with that cultural context. And so traditional messaging related to recruitment, but also within the apps that might have a simple symbol as like a rainbow flag that's traditionally utilized to say, this is a program, this is a safe space, this is an entity for people like us, does not necessarily work well within that same rural context. Instead, what we see is individuals will go ahead and try to not approach a flyer or entity within that community sphere that has any type of image that might lead to inadvertent outing. Similarly, when we think of a lot of the work that Dr. Roth, myself, and others are doing relating to mHealth, it might have some type of push notification or notification to it says, either for a daily diary, taking medication, whatever that could be. For myself, accessing your STI results. What does that message look like? How is it going to come across as the screen? Do you want it to be something more forthcoming? So this idea of a project we have about empowerment, looking at your test results are now ready for viewing. Is that what you want to come across on that notification? Do you want it to be email based? Do you want it to have a push notification? What should it say? Similarly, when we're thinking about that login screen, is it just something where you want an easy access, opened it real quickly, or some individuals might want that two-factor authentication to kind of protect their privacy, so making sure that no one else can get in. One of the biggest things we start to see within this is also looking at how data is stored and how data is transferred. What are we putting in there related to our sexual behavior, our substance use history, and what happens once it's been put into your phone and it's mysteriously getting to the researcher? How is it being downloaded? How is it going through the cloud? And so a lot of these concerns are things that we as researchers and practitioners can present to participants on the forefront to kind of alleviate some of these concerns, and how we can get feedback from those participants on the forefront when we design the actual intervention. And so I want to pose some quotes from participants within some of our various studies that have looked out. The first two really have to do with this concept of risk. So this idea of this is a good old boy town, you do things at your own risk. Most of us aren't out around here. If people find out, you never know who you may lose or what may happen to you. Similarly, I keep these things close to my chest. No one needs to know my business, especially about personal stuff. Who is going to make sure my business doesn't get aired? That type of stuff can come back to bite you and ruin you. So a lot of these men talk about the physical and social risk related to inadvertent outing within a community that based on what's on your phone could be seen by somebody. Think of pre-COVID days, if we were actually at a restaurant and something pops up, a friend could see it and start to question what that may look like. Similarly, they start to look at how they can construct narratives to protect themselves, but also how this cultural context come into play. So this idea of not many folks understand living out here. It's a way of life for us. It feels different, and it is different. There's no question out here the rainbow has mud on it. It's all about trust. Why should I trust you, and why you should trust me? How you have rural and gay folks being involved. They know what is at stake for us, and they know about our experiences. So this speaks to the community-based engagement approach that our colleagues and I use about getting feedback, but understanding the real world experiences of how these things might then be implemented. So we can think of mHealth and telehealth, especially within the COVID context, that this is really kind of a amenable care modality that we see even with the rural context for sexual gender minority men. We know that there were kind of ubiquitous cell phone ownership among this population, excuse me, and it's a promising platform for the delivery of care, especially for those who are hard to reach and who are not accessing HIV prevention or STI prevention services typically within their own communities. These communities are kind of aware of the potential risks within some of this research, but they also start to look at what are some things that they can strategize for risk mitigation. And so I think as we go forward too, and we talk about things like COVID has led to a large amount of funds being put into telehealth and now into mHealth as a way to expand care accesses. And so how can we work with these providers and provision to make sure that it is congruent with privacy confidentiality concerns or other ethical implications of widespread rollout in a shorter period of time? Thank you, and I will turn it back over to my colleagues.
Dr. Hubach, thank you so very much. That was a fascinating presentation. We're going to turn it over now to Roman Shrestha. Roman, why don't you take it away? And just a reminder, if you have questions, we'll be taking questions at the end of Roman's presentation. Feel free to send those to myself or to Steve. Go ahead, Roman. Thank you.
Thank you, Elizabeth. All right. So I'm going to talk about the use of mHealth technologies for HIV prevention. And I'm going to go, from a different lens in terms of coming from an international setting. And I'll take my ongoing research in Malaysia as a case example, talking about some of the issues related to access, also some ethical challenges that arise as we use this platform for different, different kind of research, and also some of the recommendations for future implications. So Malaysia, HIV epidemic in Malaysia, just going briefly, it's one of the countries globally where HIV epidemic is increasing. So even though the overall prevalence is low, the infections is really increasing. And this is especially the case with MSM, men who have sex with men. So looking at the data from 2008, where the incidence was about 10%, and it has significantly increased up to 54%, and this data is back from 2018. And one of the issues, what's really striking, is the coverage of different HIV prevention programs in the Malaysian context. So looking at access to different services, for example, PrEP, which is pre-exposure prophylaxis, one of the biomedical tools available for HIV prevention. So the access is really low. So that kind of speaks to why there's an increasing incidence. And one of the reasons, or a few of the reasons why the access is so low, is probably having to do with stigma, discrimination, and also criminalization of homosexuality. Malaysia, where drug use and also homosexuality is criminalized. So it kind of gives that dual burden of stigma and discrimination. And it happens not only in the community, also in the healthcare setting as well. So these people, these segments of population are really not willing to share their sexual risk behavior, also their sexuality with their healthcare provider. And it kind of makes them marginalized from their healthcare, from their traditional healthcare setting. So they're not going into the traditional best the venue-based healthcare services. So it is very very problematic because there isn't any other avenues for them to go to in terms of accessing care. And also calls for innovative services in terms of how we can, get these services out in the community to people who are really hard to reach and are really marginalized. And the issue having to do with mHealth is that the research has shown, or the data has shown, that there's an increasing use of mobile technologies, particularly smartphone. So if you look back from 2010, where only 14% had reported to have smartphone, and it has increased significantly up to 76% in 2017. And also there's a similar pattern in the rise of internet in the smartphones. However, as of today, there hasn't been any mHealth studies, particularly looking at how we can use that platform for HIV prevention effort. And that's what this mHealth based approach comes into play. And like my colleagues has already mentioned about how this platform could be used, is that it's not just the app or the text messaging, it's the different kind of devices, wireless or mobile technologies to support different kinds of health outcomes. And the reason, which is really important, particularly for Malaysia, where there's the criminalization or more of a stigma and discrimination associated with just being gay or bisexual or transgender, is the issue related to confidentiality and stigma. And this mHealth kind of provides that confidential and convenient way of accessing care. And also many times, if everything is happening virtually, you don't have to face the doctors or nurses or clinicians. So it kind of, it decreases that risk, decreases the stigma and discrimination. So it provides that safe virtual platform. So, and probably that's one of the reasons why there's a huge, there's an increasing number of HIV related work using mHealth platform in the recent years. And this is particularly, important in the case of COVID, where, many people, especially in Malaysia, they were already not going to the venue-based services or clinics to access care. And this has become even worse during the age of COVID-19. In our recent study, we looked at how COVID has disrupted their use of different HIV prevention services. And we found out that about 63% of people said that they're not accessing HIV testing because of COVID. In terms of STI testing, it was about 59%. And in terms of PrEP, which is pre-exposure prophylaxis, about 25% who had trouble accessing these services. And we then asked a follow-up question in terms of if there was an app, or if there was an app which could help you in accessing this care, do you think that would be helpful? And there was a there was a positive response from the participants that would have been extremely helpful if app was present, especially in the times of COVID, where they didn't have to go to the community and get access to those services. So, and this kind of brings us to our current work, which is looking at how we can use app. So basically, at the moment, we're working on developing an app for HIV prevention, primarily on improving access to PrEP and other different HIV prevention services in Malaysia among men who have sex with men. And we've conducted a series of formative studies looking at what their preferences are, what are different features they would like to see in the app. And some of the key features that are listed here in the slides, looking at how they would prefer chat function to get in touch with clinicians and research staff, having a discussion forum which kind of provides them an open and non-judgmental space to get in touch with their peers, being able to create plans for HIV testing, and also getting linked with PrEP services. Having that virtual way of getting the labs done, whether having the delivery, automated delivery, e-prescription. That way they don't have to go to the clinic. Being able to receive tailored messages, whether it's reminder messages or other ways of getting different feedback messages. And things like that. So these are lots of different preferred features they would like to see in the app. So, but with all these, and probably many of us here could agree that mHealth, or app in particular in this case, would provide this many benefits in terms of accessing services, right? But one thing which is really important that we should be considering is looking at the ethical challenges or legal challenges that comes with using app platform for HIV prevention or any kind of other works. So because this app or the mobile technology in general has the capacity to capture a wide range of data or vast quantity of data from the potential user. So we should be really, we should be thinking about how different ethical challenges could come into play, and how to best address those challenges. So some of the key themes related to ethical challenges that has come in our own study and also in mHealth study that has been published are issues related to privacy, who owns the data, and in terms of control over how the data is shared and stored. So one of the big issues in terms of privacy is having the data hacked by different third party, or in the case of Malaysia, one additional thing is government interception. If there's any illegal behavior that are being discussed within the app, or if they have shared their engagement in same-sex behavior with other people or even with the counselor, what would happen if the government find out about that? In terms of informed consent, making sure that people are aware of different risks and benefits. Especially working in low and middle income countries, whether the language and the consent is appropriate in terms of cultural context and also linguistically. And issues related to storing and sharing of data, where the data is being shared, who has access to data that the users are sharing with the research staff. Also the issues related to communication of result. And this is particularly important in the clinical care, making sure that the participants are provided with immediate feedback so that they'll be able to maximize the benefit of using mHealth platform. And the issue related to access to mHealth technology, and it also talks about justice. Are we reaching out to the people who really needs this platform to access care? So ensuring that all the vulnerable population have access to this intervention is really key. And also issues related to regulation of mHealth products. Is there a regulatory body who can provide guidelines and also support as these platforms are in the planning phase, also in the implementation phase? And given that there are so many mHealth projects out there, making sure that they are being evaluated on a timely manner and the results are being shared to the community, which ensures the benefit, the maximum benefit of the platform. So this slides kind of shows different ethical principles, which is really important for mHealth research moving forward. And it more so applies more into the LMIC, low and middle income countries, looking at how different stakeholders should be working together when we're thinking about developing an mHealth platform to address different health conditions. This is especially true in developing countries because many times the funding is coming from the outside organization or foreign organizations. So building capacity, which ensures sustainability at the same time, is really important. And the other issue, the other principle related to fair selection of these participants in the studies are clinical care using mHealth platform, making sure that we are identifying and protecting individuals who are using it, and also making sure that we are reaching out to the right population, making sure to ensure the scientific validity of the research. And in terms of favorable risk-benefit ratio, making sure that we're assessing different potential risks, whether the risk are related to the physical risk or social, behavioral, or psychological risk, and also legal risk. For example, in the case of Malaysia, making sure that the participants are knowledgeable about that, and also about the benefits of being of participation in such research. And in terms of informed consent, it's really important that we involve the community while we are in the planning phase of the whole mHealth platform development, and also disclosing information in a competent manner, taking into account of the cultural differences, and also making sure that it is linguistically appropriate. And ensuring that people have the freedom to refuse or withdraw from the study or the clinical care using mHealth platform. And lastly, respect for participants, because the ethical conduct of the research doesn't end with just by obtaining informed consent. It continues even after the participant is done with the study. So we need to make sure that there are proper procedures in place to protect the confidentiality of the participants, and also making sure that we are informing participants and also the host community of the research that we did and what the findings are, so that they will be able to make informed decisions in the future as well. So this kind of provides the framework, and it's really important that I think, especially in my own case, as well as we start to work on this app, it kind of provides that guideline in terms of how, not just thinking about different features, but also some of the safeguards that should be in place as we start to build and implement the app. So that we can maximize the benefit and reduce the risk that the participant may have to go through. So with that, I'd like to thank my collaborators and also the funding agency. And thank you.
Okay, thank you so much, Dr. Shrestha. Thank you to all of the presenters. We have time now for questions, and I will read the first one, and I think we'll start with Dr. Hubach for this one. How should we understand the relationship between mHealth technologies and the patient-doctor relationship? You mentioned that this can help overcome barriers to care when there aren't adequate or accepting providers, but could these technologies also threaten to disrupt existing relationships or prevent positive relationships from forming when patients can try to address their own health concerns without a doctor?
Yeah, and that is definitely a great point that has to be made, is that it can be utilized as a tool, but it can't necessarily overcome some of the benefits of inpatient relationships. Particularly what we saw, we've done some additional work looking at the amenability to telehealth and what they would want to see patient forms and what they would not, or would want to see a provider in person for. And one of the biggest issues that we've seen was their lack of current access to care. So we have qualitative data currently about some of these rural men where they've gone to a provider, disclosed their sexual orientation or sexual behavior, and the provider has provided them a pamphlet for the church down the road, or they have refused to see them again, essentially saying that you'd be better served by a clinic within the city. And so utilizing telehealth or telemedicine isn't necessarily the perfect answer, but it definitely allows for a linkage to an affirming provider. And so how can we then start to, within even a medical school curriculum, start teaching about the utilization of telemedicine and telehealth and building those relationships with your patients with that? Because I think the reality of the situation, and COVID has just now spun it a little bit faster, is managed care systems are going to push forward telemedicine given the cost reduction and everything. So how can we start to then build into that educational component too?
Thank you. Alexis, Roman, any other comments on that?
Yeah, I mean, I think it's also worth mentioning that telehealth is not one size fits all, not in terms of data collection and what people will be amenable to, and certainly not in terms of the delivery of interventions or care. And so, I have a study that was funded by the Fordham Center for Research Ethics, where we're looking at, what happens when the FDA relaxed some of their guidelines around buprenorphine prescribing. And that happened in the context of the COVID era. And so for participants who have access to this telehealth program, it's great, except for like in my case, the populations that I work with are unlikely to have telephones. They're unlikely to have consistent phone numbers. And so do they have access to that program? And then should they have access to the program? Like what constitutes whether or not they're a telehealth patient if what they're doing is showing up to the community-based organization, borrowing a case manager's phone, and then using that to call the doctor. And so, I mean, I just think that like there's really, as access to these services grow and change, we're really going to need to think about how can we utilize these platforms for a variety of different populations, living and working in a variety of contexts, given the difficulties that they face in terms of like navigating care in particular, no matter what.
Yeah, thank you. Roman, any further comment?
Right. I think it just adds one more tool to the existing tools, right? It doesn't replace the traditional way of accessing care. And I'm talking about Malaysia in particular. I mean, as people start to go virtual, there are still some components which needs to be done in person. For example, not all tests could be, home delivered. So there are some tests they will have to go to the clinic, and that has to be done by the clinician. So I think moving forward, it does, finding different ways of continuing the service. At the same time, they are still using some traditional ways of accessing care.
Thank you. A related question for all of the presenters. How has COVID increased health disparities among the populations that you've all been working with? What public health approaches have increased health inequities during COVID? And what kind of public policy response would you like to see that can help reduce these disparities? And Randy, why don't we start with you?
Put on the spot.
Put on the spot.
I definitely think, especially from a harm reduction or for our substance using populations as well, it's been a challenging time within rural communities because we have this public health response where we needed to shut down a lot of entities in order to maintain the public's health. But by doing so, we unfortunately also shut down a lot of these safety net programs for individuals within rural communities. I'm thinking about HIV and STI testing centers, some of our local prevention, outreach, and treatment centers for substance use. And so part of it is at what extent do we maintain the public's health, the larger public, but at that same time, we're hindering subpopulation's health. And so I think that's been kind of a unique reflection that we can have within the pandemic. Sexual and gender minorities, with the research we're doing now, the utilization of telemedicine has been helpful for them and they want to continue to use it. But the question they have is, what happened when it goes away? So if policy doesn't keep up and say, yes, we can continue to use these programs post-COVID, you've adapted in such a way that is beneficial to the patient, to the client, but could that change later? And I could see that, I think Alexis's work too, that the prescribing policies related to whatever, I can never say it correctly, has changed, and there's been waivers and things that have been done in the COVID era that now patients are amenable to it, it works. But what happens if those policies are kind of rolled back too?
Alexis, do you want to follow up on that?
Yeah, I just think, and that's, part of the grant that I'm working on, right, is to frame this within the context of an ethics study. And if participants experience a benefit, then is it ethical to take away a policy that was created in a given era that could then, further exacerbate existing health disparities, both among folks who use drugs, but also subpopulations of folks who use drugs, which we see are being exacerbated now for Black and Brown folks. I think the other thing that Randy was saying that's super important is that, these safety net programs like syringe exchanges, they're there as an evidence-based practice to prevent HIV. They do a whole host of social services, housing, and things like that. And when those services go away, folks don't have a lot of choices if they don't have resources to engage in health behaviors. And so then that's another question, right? Like, I know that the guidelines that these sort of essential businesses received varied a lot from location to location. And so when we think about like, when is I'm sorry, I don't know if you guys can hear, my toddler is like screaming. I don't know why. Sounds like he's being murdered. I don't know. I just think that but so I just think in the context of like preparedness for this next public health emergency and these shutdowns, like how can we keep these safety net, these essential services running in a way that's safe for them to deliver these just like incredibly life-saving services that prevent disparities, or at least try to diminish disparities.
Yeah, thank you.
Right.
Roman?
Kind of served as there's many different, different negatives about COVID-19, but looking at the positive aspect is it kind of served as a disruptive innovation, especially looking at how we could use mHealth platform to improve access to different services. And we currently have a project going on in Malaysia where, we're trying to improve access to HIV self-testing, and people were not able to, access HIV testing. So what we have started doing is they're being able to order testing kits, and we are, delivering them to their preferred home address or other addresses. So it kind of serve a purpose, and hopefully we'll be able to continue doing that even after the COVID pandemic.
I was going to add something to that. So being in Oklahoma, we work quite a bit with the tribes, and seeing the ability of the resilience of the tribes in the time of COVID to kind of move their resources to address the epidemic compared to other areas within the state, and the amenability to roll out things like at-home testing that could be mailed or delivered, or developing program that's now been moved into a mobile platform. But also you start to see change or look at differences within tribal groups. And so the larger tribes that have that income and revenue, their ability to respond look quite differently than a lot of the smaller tribes, especially what we see within New Mexico and Arizona. And so it does give us kind of from a social justice perspective, what's occurring within groups, but also at the same time, even with vaccine rollout, the way that communities are prioritizing, tribal elders for speakers really creates a unique conversation that maybe as a nation that we also should be having.
Yeah, well put. We're going to go back to Roman with a question. Roman, how do you include these vulnerable populations within app development, considering the barriers mentioned for app use, for example, the fear of government interference and sharing their identity?
So one thing that has been really helpful, in our research group is being able to connect with the community. So we've been working with the MSM community for a while now, and also with not just the community in general, but also the providers as well. I just wanted to share a really nice experience we recently had. So when I had first visited Malaysia a couple of years ago, and we talked about using mHealth platform at that time, and there was just so much resistance from the clinical, especially from the clinician side. And now in the last few months, we mentioned then that we have a grant, and then we can now develop an app to help improve access to these services. And they're now coming to us like how we can use this platform, given that not many people are coming to the community, to their clinics. So that's one thing that's been really helpful. Being well connected with the people out in the community and also the providers. So that collaborative approach has been really helpful in reaching out.
Thank you. Okay, we have a question for all of the speakers. And it says, a lot of people are concerned about apps, et cetera, collecting and sharing and selling personal information or being used for marketing purposes. Especially if the apps are free, there's the idea that if you're not paying for something, then you are the product. These concerns seem especially pressing when it is private health-related and behavioral information. How much should consumers worry about this? And as these technologies proliferate, how are these technologies regulated in this regard? Anybody want to start?
Maybe. So I mean, I think that those are really salient points and really important things that we as consumers should be considering. I think it's a little far afield, at least from the work that we've been doing, in that we are designing these apps that are being utilized in tightly controlled research settings, which is very different than some of the social marketing or platforms like Facebook or anything else that you might imagine. And so I think that there's a distinction here in that we have to worry about how we store and access our data, but the participants are giving us a certain set of permissions with informed consent around what that looks like. And then it's our responsibility to manage that and keep their systems safe. So it's a little bit different than a commercial commercial application, but I think that's a great point. And I don't know if Roman and Randy want to speak or Celia want to speak to that.
Yeah, just adding to the difference between commercial and the research platform, it is really distinct because when you're using some commercial app, you just have to agree to all the terms and conditions, right? And that may not be the case with the research. I mean, it may be the case to some extent, but they have the ability to not participate, and making sure that everything is laid out when we do the informed consenting process, making sure that what information is being collected and how it's being stored and things like that. And particularly in the case of Malaysia, when we did our formative work just recently, one of the reoccurring theme was, does the government will have access to this data? That just kept on coming in all the focus group that we've been doing. So and I think it was really one thing that we kind of learned from those sessions were that making sure that this data will not be shared with anyone outside of the research study is really key as we start to think of what should be put in place in the consent form when we do actually do the RCT in the near future. So that was a key.
Yeah. Dr. Fisher?
Yeah, I just wanted to add two of our, kind of institute alumni, Brenda Curtis and also John Rendina, have done some research on this. And so, I think Alexis and Randy and Roman have been talking about the responsibilities of the researcher, or if it's going to be a physician taking over. But one of the challenges is that when we're recruiting through something like Grindr or Facebook or anything else, they are collecting this data. We don't have control over that. And John Rendina did an interesting study where, people were more trusting of research than they were of the companies in which the research was being recruited on, like Facebook or, Instagram, but they didn't realize that in fact, all of their data is being collected. You put an ad on and you say something like, you have a picture of a transgender person. Well, Facebook now knows that. They can start selling to companies that maybe are interested in that. So anyhow, it's a very interesting question in terms of we do not have control and what is our responsibility to be informing other, the people that we work with, that in fact, as with anything else, these companies may have access that we have no control over.
Okay, let's move on to a question for Dr. Roth. In light of the recent controversy with Nick Jonas and Dexcom about their Super Bowl ad about a diabetes health product that many cannot actually afford, how are thoughts about funding for Biosense OD and its future enhancements be thought about, and how will you ensure that people have access?
So I'm going to admit something to all of you, which is I didn't watch the Super Bowl. I don't know about this scandal, but I can speak to your last point, which is really important, which is around like, how do we ensure equal access? And so what I didn't talk about in the talk, because we had very little time, is that the biosensor that we selected totally didn't work. I mean, that's not true. It didn't do what we wanted it to do. We wanted to be able to capture SpO2 and respiratory rate and activity to be able to have a triangulated measure of overdose experiences. And we were only able to gather respiratory rate. And then we compared that to self-reports, and we didn't, according to our participants, have any overdoses. And we also, the respiratory rate didn't indicate that we had any overdoses. So that's a great finding. But I wouldn't, if I was somebody who uses opioids, this device isn't able to do the interventions, the next step interventions that we would want it to do. So it doesn't alarm, it doesn't call for EMS, it doesn't trigger naloxone. So we need a commercially available device like that, and we need to think through the payer structures for that. So we just applied through like a Drexel mechanism to work with some engineers and critical care pulmonologists to design that device. And part of what that competition requires is for you to have a plan around payment. And so we're trying to think through how could we involve like health insurance companies, safety net insurances to pay for a device such as this one. These kinds of devices get paid for other things like COPD. And so if we could find a paying infrastructure, that it's possible that those things could be covered. And so that's part of what we have to stipulate as a part of that grant. And so we're working through those issues because they're just exceptionally important, right? And let me also say that like, it's not just the case that the folks who would benefit from a device like this are homeless persons who are sort of what you think of as like a quintessential person who used drugs. Lots of people use drugs, right? And lots of people are coming out of rehabilitation centers and are at risk for relapse, which is a critical time for when somebody might experience an overdose. There's lots of chronic pain patients. So there are the worried well who just had like a surgery and are worried about taking opioids at all given the current crisis. So I think that, it's important to think about that this kind of a device could work for a bunch of different patient populations. And so rolling that out in these different and tiered strategies for payment will be really important.
Yeah, very helpful. Randy or Roman, any follow-up on that?
I was just going to say, I think this speaks to the idea of, as researchers committing to, as we're building things, using open source methods that could be shared with other entities as well. I think one of the biggest things, even from an academic standpoint, is you have institutions that have the financial resources, even with our grant history, that could build a lot of these products, which still can keep it located within certain areas of the United States, where you have resource limited institutions and researchers who might not be able to get that type of build out. And so if we use open source software and the like within mHealth, how could it be tailored and utilized by researchers, but also community-based organizations that are just building off of a evidence-based platform that's already there?
So just adding to to the two discussions. So in terms of particularly the app, just doing some formative work in terms of what technologies these individuals have access to, and can we build off of that? For example, whether, you know, if they don't have access to a smartphone, whether it makes sense to give them a smartphone and do the intervention, and what would happen once the study is over. So, you know, that's where we did think about it before we actually planned to go for the app intervention in Malaysia. And turns out that everyone has access to, or most of the people have access to smartphone. So that's one thing that's really important. And the other thing, in terms of developing an app and making sure that it's being regularly updated even after the study is over. And touching upon that, I think it's really important to build capacity and making sure that people who are taking ownership of the app, or who does have the capacity to make sure it's being maintained well even after the study. I think those are really important as we think through you know, developing and implementing these platforms.
Thank you. Okay, the next question. Each of you described how the people you work with see their neighbors as presenting risks to their health and welfare. Is mHealth the answer to this if it disguises their identity, or in the case of drug use, addresses isolation? But will the health disparities for MSM or drug users persist if we do not address community stigma? And if so, how? And if so, how? And we'll...
So
I'll go ahead, Roman.
Go ahead.
Everyone wants to start. Okay, Roman, why don't you go ahead?
I think there are many things that, you know, that needs to be addressed, and, you know, with the app or with the mHealth, you're trying to address some aspect of it. It can't, you know, take away all the stigma or, you know, everything. So, you know, I think personally, if you're able to take some aspect of the stigma, for example, if someone is not willing to go go in person to the clinic, and if you're able to make that service accessible, for example, through virtual delivery, if that is successful, I think you're addressing some aspect of the stigma. Yeah, so I think, you know, it's just making sure that you are contributing to, you know, addressing some aspect. Yeah.
Yeah, I always like to. Oh, sorry.
Randy, go ahead.
I always like to say that stigma is probably the worst determinant of health of them all, because stigma drives behavior underground. And so we're not really understanding what's occurring with the community, and then people are less likely to access care. And so when we think about the need for community level stigma interventions, if we could just get one that works, we would solve a lot of issues. And I think that's one of the bigger problems, is the financial costs and the ability to do such a large intervention that would actually be efficacious. And so understanding that these social contexts have to change over time, and in like places like Oklahoma, we wish it would move a little bit faster, but that, you know, how can we meet clients and community members where they're at? And so understanding that we're hoping for these cultural shifts, kind of as Roman was saying, that can we at least provide access to care, or in some of these, you know, if you're a rural gay man, and a lot of them talk about if they pull up Grindr and the next person that's pinging is 15 miles away, well, at least you can develop some type of virtual support group as well. And so those people might not be around you, but at least you can start to build those relationships in a virtual sphere.
Thank you. Alexis?
Yeah, I mean, I think that the gentlemen have touched on two really important issues. And in another study, the Unity Philly study that I mentioned, it's a smartphone-based application that links together a community of lay first responders who've wanted to be a part of the Unity Philly network, who are there and who are ready and available, not all the time available, but at least equipped with naloxone and educated about how to use it and to detect an overdose. And people can trigger this app much like you would call for an Uber. And what happens is somebody in your community, the three closest people to you, get pinged to come and respond and assess. Now, granted, people who are overdosing normally aren't calling this on themselves. It's they're seeing someone who has the app is seeing someone who's overdosing, and they've realized there's a crisis. And so that doesn't necessarily help the person overdosing from a social support in that moment. But then when they wake up, there are people around, and they're not necessarily the people that they were afraid who were in the community who were going to run their pockets, but rather people who have volunteered to be a part of this emergency response community. And through our pilot trial, what we learned was that our responders showed up on average 5 minutes before EMS. When you're talking about oxygen and oxygen to your brain, that is a very critical window for preventing, really acute long-term effects, if not death. And so I think that apps like this, as Randy was suggesting, and Roman was suggesting, they can both pick it a little piece of the problem, and then also connect in other ways.
We have about 15 minutes left. Another question has come in. Do you think your populations will take the COVID vaccine when it is available? Or is distrust in medical providers too great in rural US, Malaysia, and among racial minorities who use drugs? And is there a solution to ensure they do not become at continuous risk to COVID? Randy, do you want to start with that one?
Dr. Fisher, did you write that question?
This is supposed to be anonymous. Hey.
I do agree. I mean, rural communities, I think, are disproportionately at risk when it comes to COVID, and we're going to see low uptake of the vaccine, unfortunately. And so I think a lot of these systemic issues of governmental distrust or thinking of government overreach, I think are going to impact not only rural communities, but we think about intersectionality identities of American Indians living within a rural environment, sexual and gender minorities, how are they going to get access to it? It might be, since they don't have to see a provider directly, but it's through the health department, maybe that uptake will be a little bit higher. But within the rural context, Kaiser Family Foundation, just the last data that came out a couple of weeks ago, was founding that about 30% of rural Americans had no intention at all. Not like, oh, maybe, like, nope, not happening. That said, nope, not going to take it. And that becomes quite problematic from a herd immunity perspective.
Roman?
Same case in Malaysia. The vaccine hesitancy is a real problem, not just in the States, but also in Malaysia as well. I think that's one of the reasons is not just access, but people are just, getting misinformation via, Facebook or Twitters or different outlets. And I mean, I think, one of the reasons why there's a surge in cases, Malaysia was opened a month ago, and because of the, the increase in cases, it's back into lockdown. And unless there's some form of intervention and then making sure that, people are getting enough access to vaccine and they're actually taking it, I think it will be a real problem if it's not, properly intervened soon.
Alexis?
Yeah, I mean, I think that we know that medical mistrust exists in these communities, especially communities of color. And there's this long legacy of the historical experimentation through things like the Tuskegee that will be impediments to people considering any intervention. We also know that, at least as of last week, it was something like 20% or 5% of the people who had been vaccinated, which is still a pretty low number, were African American, though they make up 13% of our population as a nation. So it's just like I'm still being in Philadelphia, where we just had the Philly fighting COVID scandal, and all of our sort of delivery of vaccine sort of stop. I'm so worried about just getting equitable access. I think if we can get equitable access, that people may surprise us by what they're willing to do. But at this point, it just seems like, here, at least in Philadelphia, where we have high rates, like by the time, I mean, it's just going to be it's going to be such a long time before people have access to vaccine. And it's really unfortunate.
And I think we could start to look at how mHealth and other technologies could be used to address these issues related to, health literacy, trust, how do we engage popular opinion leaders to start having these conversations among community members that, yes, we have to have equitable distribution, but there's definitely things we can do in the meantime to kind of build up individuals' intentions to hopefully get the vaccine when they're queued in line too. And social media messaging is going to be important. I think mHealth also will have a role with that too.
Thank you. Okay, another question. It starts out very far afield of what you're talking about, but I was very curious if you had any thoughts about contact tracing apps. Naively, it seemed like these could be promising tools to help us control COVID, but it's not clear they ended up getting off the ground in any substantial way. Given your experiences in mHealth generally, can any of you speak to whether these technologies could have been more effectively utilized, or were they always going to be non-starters? Or could you help us think through these, when would it be important to understand, what would be important to understand when thinking about such technologies?
I think it's being used in China, right? I'm not sure about in the States, but China, they've been using contact tracing. And also in India, there's where it's mandated that healthcare provider use some, and there's so many ethical issues that were described in the media in terms of if you're making someone use it on a mandatory basis and what kind of ethical issues that comes because as you are using it, there's geolocation and many information that is being collected and who has access to that and what that information will be used for. So,
yeah, I think because I think some of those were talking about the fact that we would have to download an app or something to where things would be tracked. And there's been conversations that we're all being tracked anyway. And if you're using a cell phone, they know your location. And so is there ability to ping people who are at a cell phone tower or something that might have been an exposure with it? Unfortunately, I think COVID has highlighted how drastically underfunded our public health infrastructure is and how understaffed it is. And so to address the next epidemic, I do think we have to have conversations of how can we use technology to do contact tracing and how would it be effective even for STIs and other communicable diseases. But can we be proactive to start getting feedback from community members related to it? Because when we're reactive, that probably raises more issues within rollout too.
Alexis, any comments on that?
I think we've been doing contact tracing for a long time in this country around things like sexually transmitted infections. And so we know how it can be done ethically. How that translates into a mobile platform, I'm not sure, but certainly I think that nationally and globally that expertise exists. And so, if we can think about how to take from best practices in terms of infection control, it isn't the case that we necessarily have to have reinvented the wheel. Yeah.
Okay, good. In the time we have left, you've all given us so much to think about. In our audience today, we have other researchers, we have students. So is mHealth the future of research? What would you say to young researchers? You're all young, but to researchers starting out, what are some best practices as you enter into mHealth research and this modality? Do you have any words of wisdom?
I go first because I think my toddler is about to come bursting through that door. Hi, it's Joe. Come here, buddy. Come be on. It's okay. So I think that the questions around the community engagement that people were asking about, like how do you design these technologies? I think that that's incredibly important in like any kind of research that you're doing, that sort of formative work to understand like community needs, what's acceptable to participants in terms of communities in terms of what they are willing to give you with their information, what kinds of data collection strategies that they're interested in. And so there's like a whole area around like consumer driven participatory design. And I think that that's just like incredibly important in all types of research, including health research. Like your stakeholders are the most important people for helping you plan and execute good work, and also like good programs once you figure out what's the right kind of intervention when you start to think about bringing these things to scale.
Randy?
Yeah, I would echo what Alexis was saying, that I think it has to be that community engagement and looking at best practices, and mHealth is one tool that could be added to that toolkit, but it doesn't necessarily have to be the end all be all. And so as we're looking at our multi-pronged approaches and looking at addressing various ecological layers, that mHealth has a component, maybe at the individual and interpersonal level, but not to be foresighted in the of how we must address some of these other layers of influence too.
Yeah, thank you. Roman?
Yeah, just adding to that, most of the times I think we just get so excited about using app and how it could be used and what features I would want, rather than what the target audience would like to see. So going through that formative work is really important. So not what works for me doesn't always work for the other people, especially if we're working with marginalized, hard to reach populations. So that step is key as you start to think about planning and developing, in addition to the partnership and capacity building and other things we discussed earlier.
Thank you. Okay, as we start to wrap up, I'd like to thank our presenters, Dr. Roman Shrestha, Dr. Alexis Roth, and Dr. Randy Hubach. I'd like to thank Celia Fisher, Dr. Fisher, and Steve Schwartzer for their leadership of the Center for Ethics Education. These sessions are, remind me, Steve, monthly, so you can check out the schedule for the next session, and Steve may have details on that off the top of his head, but I don't.
So our next session is on February 22nd.
Great.
And then
Great.
we will have 2 more sessions, one in March and one in April.
Okay. Well, on behalf of the panelists, thank you for joining. Steve, if you have any other concluding comments, I'll turn it back to you. And thanks for everyone for joining tonight. Great questions, great conversation, just amazingly important work that all 3 of you are doing. Thank you for all the work that you do. And thanks to the Research Institute, READY, for its support. Dr. Fisher, this is an amazing project, a program that you have. So thanks.
And I would just also like to reiterate the thank yous to all of you, and to you, Elizabeth, or Dr. Buchanan, for moderating the conversation. So.
Yep.